ago, when the general CT was much thicker slices, so 5 millimeter or 2 millimeter slices. These days, we recon most CTs on 1 millimeter. So literally any CT chest is an HRCT if you think about it. Just the appearance of the recons can be a bit different, so they can appear a bit different. But the technical term of 1 millimeter slice applies to most CTs that you report every day. The differentiation is more about who gets to report those CTs. So HRCTs, if labeled as HRCTs, end up with chest radiologists or more specialist reporters in more larger tertiary care hospitals. So like I said, reticulation in a very general form means lines. It can be thin lines, thick lines, small ones, big ones. So most commonly it represents interlobular septal thickening. Interlobular septal thickening just means thickening of the space between two lobules of the lung. Just based on what sits as a normal structure in that space can tell you what it would mean for that to be thickened. So the normal interlobular septa shouldn't be visible on a CT chest, no matter how thin and how clear a CT. So if you see the interlobular septa on a CT chest, that implies that in itself is abnormal. What that means is that the structure that is sitting in that space is thickened. That structure is usually lymphatic channels or blood channels or the fibrous tissue that connects the lung together. In terms of the fibrotic lung diseases, we can say that reticulation is just thickened fibrosis or the interstitium that gets coarse and thickened. In terms of heart failure, that same thickening can actually just be fluid, so it's completely reversible. In terms of, if you think about cancer, that thickening is infiltration by cancer malignant cells, so that is the typical nodular or irregular septal thickening. In terms of ILD or hemorrhage, or sometimes some ILDs are related to underlying connective tissue diseases or vasculitis, so they can go hand in hand. Sometimes you can't really tell the difference. Sometimes it's going to be a combination of both. So interlobular septal thickening can be smooth or irregular. If it's smooth, if it's the first scan that you're reporting, you can't really tell that's permanent or temporary. If that patient is a heart failure patient, it's an inpatient that presented with fluid overload, has a large heart, has coronary calcification, is 85 years old, and has a bit of basal septal thickening, you're not going to go ahead and call it an ILD. You're going to describe it as smooth septal thickening in the context of cardiomegaly, etc., most likely a degree of fluid overload. In most, the confounding factor comes in when it's the same patient cohort. So it's the older, more frail patients that typically present with idiopathic ILD, and it's the same age group or the same sort of patient that will present with a cardiac abnormality. So sometimes it can be a bit of both, and sometimes you can't really tell them apart. So that's the septal thickening bit. The nodular irregular septal thickening, sometimes people want to see very clear beading of the septa. It's not really as clear as that. Sometimes it can be very subtle. Actually, the more common presentation is very subtle irregular thickening. And the most concerning differential diagnosis in that nodular irregular septal thickening is, of course, malignant infiltration. You have a few specific cancers that give you irregular nodular septal thickening, and the most common one we see every day is breast. So when you have isolated irregular nodular septal thickening in a patient who has no history of cancer, that's not the first thing you're going to say on the scan. If it's a known patient or a known survivor of cancer, even if that's 10 years ago, breast cancer, most common presentation, even if you don't know the history, you see a mastectomy or bilateral breast implants, something along that line, or in the exam scenario, you have that history with you. In that setting, that patient whose heart looks healthy, doesn't have coronary calcification, and has irregular nodular looking septal thickening, that is the patient that you're going to think about lymphangitis carcinomatosis. It's not the most common diagnosis, but when it's clear, it is very significant for the patient. It implies a very bad prognosis. So be very careful when you imply that on a scan. So that's reticulation for you. And in terms of reporting in HRCT, what you're looking for is lines, and the most common place you see them is a subpleural space. So the subpleural space is not just the space next to the ribs or the next to the chest wall, Subpleural space is also next to the fissures. Fissures are also pleura, so that line, that reticulation can not only sit here, linear, next to the chest wall, it can also sit next to a fissure as well. So that's also subpleural. So subpleural reticulation just means thin, short lines sitting in the very periphery of the lung, most commonly at the lung base. I just put this slice in just for context, is that curly B lines, the very conventional sign we all get taught, is also just interlobular septal thickening. It's just the same thickening that we see on a chest X-ray. The curly B lines you get taught are the A, B, and C. B being the most common ones, because these are the ones you can see most easily. And when you see them, you know it represents interstitial edema. So the first question I would ask anybody who has reported reticulation on a scan is, are you sure it's real? It is the most overcalled and also the most important appearance that you will describe when describing a potential ILD. If it's an inpatient scan, every day you report, I'm sure, plenty of unwell patients. Every time you see an unwell patient, look at their lungs the next time. And you will see that in every single unwell patient, the posterior part of the lung, or the part of the lung that sits right next to the pleura at the back, at the lung base, looks like that. So is that subpleural ground glass, or is that very thin, subtle reticulation that looks like ground glass? Is that just dependent change, or is that real? That is more related to the clinical context you have in front of you, rather than only the scan. But reticulation shouldn't be overcalled just based on the clinical question. The first question you need to ask is, okay, fine, I see something in the immediate periphery of the lung. Is it real? Could it be explained by something else? And the most common thing it will be explained by is that it is dependent change. So when you turn the patient upside down, if you do a limited prone study, that will go away and actually come onto the other side. So that would prove that this is indeed dependent change. We don't do routine prone anymore because prone, when used or when recommended, is dependent on the reporter's confidence. Some people, when reporting an initial HRCT where the question is underlying ILD, then they do a full set of full inspiratory, expiratory, as well as prone. Depends on where you are in the world, depends on which center you work at. Everybody has their own protocols. We don't routinely do prones anymore because most of the time, based on experience, you can tell that this is dependent change. If that little bit of subpleural reticulation happens to be the only abnormality on that CT, and the clinician asks you, well, is it possible that this is a very, very mild early ILD, and you're not sure, or if there is a medical legal significance, or if there is an insurance significance, financial implication for the patient, you can bring that patient back and do a limited prone study just to prove that that was dependent change, but that's not something we need to do commonly. So first bit, reticulation, is it real or not? The other terminology we use very commonly when reporting ILD is nodularity. Not nodules, nodularity is more commonly used. It's a more descriptive term. It lets you get away with it a bit more. It's a bit loose way of describing the abnormality. Because what you're trying to say is that the abnormality I see has a bit of texture to it. I can't really say that this is a discrete nodule. I can tell that this is a bit fluffy or a bit rounded. So it's more descriptive rather than an actual scientific term. Nodularity, in terms of ILD or HRCT reporting, has very clear significance in the sense of the distribution it shows you determines the differential diagnosis you'll go down. So if you know the diagnosis already, it makes it a bit more simple. If you're reporting a follow-up scan for, let's say, sarcoidosis, it's going to be much more simple. But if it's the initial scan that you're reporting, it becomes very important for you to identify where that nodularity is, and where it can be is one of three places. It can be completely random, it can be central lobular, or it can be perilymphatic or peribronchovascular, gets used interchangeably. Random is almost a diagnosis of exclusion. So how I tell most registrars to approach it is, the first thing you need to look at when you have identified that there is nodular change in the lung. And by nodular, I don't mean macro nodules, 1 centimeter nodules, I mean micro nodularity, is you look at the fissure. If you see the fissure of the lung and it's smooth, it changes things. And if it's immediately identifiable as irregular or nodular, it's very clearly perilymphatic or peribronchovascular. So I'll tell you, not sure if you guys can see. Move this across the other way. Okay. So in terms of the distribution, this is the central lobular, or the central location of a pulmonary lobule. Right in the middle is the airway, is the end airway. That's the central lobular ground glass density. So when the abnormality is central lobular, it cannot ever reach up to the pleural surface. When the abnormality has reached up to the pleural surface, you can clearly identify or be very confident in saying that this abnormality is not central lobular. Once you've excluded central lobular, you go down the line of whether this is random or whether this is peribronchovascular. If this is random, it will be everywhere. It won't respect a pleural surface. It won't respect a central lobular identification. So in terms of distribution, in differentiating between random and peribronchovascular or perilymphatic, you look at the fissures. If the fissures are nodular or the peribronchovascular bundles are nodular, you identify it as perilymphatic. The differential diagnosis of perilymphatic distribution is very specific, sarcoidosis being the most common one. In terms of random, historically TB being the most common worldwide, it's now overtaken by metastasis. Central lobular distribution, central lobular nodularity can be very subtle in identifying, especially junior registrars or more inexperienced people fail to identify the ground glass central lobular nodularity. This happens because it's more commonly in the upper and mid zones or mid lobes. And by the time you're scrolling, you don't really go back to the apices again to look for subtle ground glass nodularity unless you're a thoracic radiologist. So it's commonly missed, subtle central lobular nodularity, and it very commonly is also an incidental finding. The reason it's an incidental finding is it's very commonly seen in smokers. So you will have that in smokers and it doesn't really give them any symptoms, and the only thing that will make it go away is cessation of smoking. Okay. So going back to the distribution of nodules, this slide gives you 4 different sorts of distribution of nodularity. So this is the first one I was talking about. Trying to move this down. Yeah. The distribution of nodularity in this one, if you look at the fissure straight away, you can see that the fissure is irregular or nodular. Then you look at the bronchovascular bundle and it's slightly beaded, slightly irregular. So you have fissural nodularity and bronchovascular nodularity. That's a very specific diagnosis to make. If you have calcified or enlarged lymph nodes, you can very confidently call this a sarcoidosis. And that is what it will be 90 out of 100 times. If you look at number 2, you will see that there is almost a larger size of nodule in the subpleural space right up to the surface of the lung. Whether that is a discrete nodule or whether that is small nodules in close proximity to each other that have kind of coalesced together and it looks like a larger nodule. And then you look at the surrounding lung, you see more ground glass nodularity around it. There's something called tree and bud nodularity. When it's very grossly prominent, it can look more confusing, but if it's very subtle or very early on, if you look at the number 4 slice, you can see that the tree and bud nodularity is more prominent. Tree and bud nodularity implies that the abnormality is sitting in the air space because it's literally outlining the end airways with the end air spaces. So if you look at number 4, the ground glass nodularity is fluffy, it's ill-defined, and it's nowhere does it reach up to the pleural surface. So where there is a very clear sparing of the immediate subpleural space. That implies that this is central lobular. When you see central lobular nodularity, you think of smoking, you think of infection, and the third one is hypersensitivity pneumonitis. When you think of infection, you want to look for other signs of infection, and tree and bud nodularity is actually a very specific sign implying infection. So in this one, in number 4, you have ground glass central lobular nodularity, and you have tree and bud nodularity. You can very easily call this as infection. Number 3, if you all look at it, if you look at the pleural surface, you can see that there are nodules going all the way up to the pleural surface. In some places, where are other places it's not. The bronchovascular bundles are smooth, they're not nodular. The pleural surface on the other side looks smooth. There are quite a lot of nodules, but they're not specific to any location. They're not centrilobular looking, they're not peribronchovascular looking. So the only pattern that remains here is random. So that's random nodularity, differential being TB or metastases. The other thing, other term we use very commonly in reporting ILD is ground glass change or ground glass opacification. Ground glass opacification comes in many cases hand in hand with mosaic attenuation. Focusing on ground glass opacification, there is shadowing or change on the CT that you can see, but it is not dense enough that it obscures the tissue behind it. So like here, if you see the ground glass opacification, you can still see the vessels next to that, so it's not obscuring it. That implies ground glass opacification. Ground glass opacification is not specific to airways. If you look at the diagram of the air spaces, the ground glass change can be the air spaces filling up with something. The ground glass change can also be very, very fine thickening of the interlobular septa, but it is so fine that it is not appreciable to the naked eye. So it can, so very, very fine fibrosis can look like diffuse ground glass change, and only time and the evolution of that change will tell you what that was. So ground glass change doesn't mean airspace. Ground glass change doesn't mean interstitial change. It just means a visual description of what you're looking at. When you have ground glass change, the thing to notice is the lung next to it normal? So in this one, if you think that the ground glass is abnormal, you have to look at the lung next to it. Is the black too black, or is the black normal lung? In most cases, it will be normal lung. In some cases, the black will be too black and the white will be too white. That very starkly different attenuation between parenchyma next to each other can be very striking to look at. And that is what is typically described as mosaic attenuation. These days, we can describe anything as mosaic attenuation, because mosaic attenuation, again, is not a diagnosis. It's not a very specific sign of anything. It is just a visual way of describing what you're seeing. So mosaic means like mosaic tiles on the walls or on a pavement. It just means different textures next to each other, like a pattern or a design. It doesn't need to be symmetrical. It doesn't need to be smooth. It doesn't need to be diffuse from the top to bottom. It can be isolated to one lung, but it's commonly described for both lungs. So mosaic attenuation can be described, for example, in this one, if you see the black and the white next to each other. In this one, if you ponder on the black one and say, is the black too black or is it okay? And if you can't really make up your mind, you can still describe this lung as mosaic. You're just implying that the parenchyma is diffusely abnormal bilaterally with changing patterns next to each other, not isolated to one lobe or one region. So both ground glass and mosaic attenuation are not specific of diagnosis. They are descriptive terms to just describe to somebody who's not looking at the scan, just reading your report of what you're looking at. This is, sorry for the amount of text on this slide, but this is just to talk about mosaic attenuation a bit more. Mosaic attenuation can be caused by two different processes. Either it's driven by vascular or it can be driven by airways. Airways meaning if the lung has hyperinflated or underinflated or filled with fibrosis, filled with ground glass or hemorrhage, or it can be that the vessel supplying that lung is abnormal. Either that vessel is stenotic or thrombosed, or over time with diffuse pulmonary hypertension. Any reason that makes the vasculature abnormal will be the vascular cause of mosaic attenuation. There's a lot of literature, if you want to read about very conservative ways of reading and assessing whether the black is too black, and then looking at the the darker part of the lung and looking at the vessel size and then comparing the small vessel size and the black or the hypoattenuating lung compared to the hyperattenuating lung, and then figuring out if the vessels are smaller. If you have a specific diagnosis in your mind, for example, if you look at that CT scan, if you've made up your mind that the cause is vascular, you can find a specific area in the lung that will make you happy, and you will be able to diagnose it that way or describe it that way. So I wouldn't put too much stress on the vascular appearance. This is more literary or more exam oriented. In real life, or even for diagnosing cases or reading cases, for the exam point of view or the viva point of view, you wouldn't really be expected to have a very specific analysis that would be helpful. So the vascular causes can be the secondary causes or they can be the primary causes. That's the confusing bit. So if somebody has, for example, gross emphysema or COPD, if you have a part of lung that is chronically hyperinflated with COPD, and over time that is not contributing to any gas exchange, the lungs are very intelligent in the way that the vessels compensate. So if there's a part of a lung that is not contributing to gas exchange, that vessel will stop supplying that lung. So the vascular changes can also be secondary to underlying airways changes. That's why I'm saying don't stress too much about what the vessels look like on the CT scan. Just identify that there is mosaic attenuation. Instead of focusing on the small vessels in the lung parenchyma, you can look at the main pulmonary artery. You can look at the main history of the patient, the right heart thickening, the right heart dilatation. Signs like that are more helpful than focusing on the microvascular structure of the lung on CT. Again, this is just to drive down the point. The mosaic attenuation, you can choose to a word you can choose or a term you can choose to describe an abnormality. In this one, for example, the sagittal view, the top is normal. This one has a bit of ground glass. On visual inspection, you can say that, oh, is this mosaic attenuation? Well, it is, but does it really imply a diagnosis? Is it helpful in any way? Not really. So would you be right in describing that lung, that axial section, as mosaic attenuation? Yes, you would be. The other sign we use very commonly, and perhaps the most important abnormality to identify in calling somebody definitively, giving somebody a diagnosis of ILD, is traction bronchial dilatation. So traction bronchial dilatation is a term that has replaced what we previously called as traction bronchiectasis. Okay, so bronchiectasis is a term that is reserved for primary bronchiectasis. Historically, what used to be called traction bronchiectasis is a term no longer acceptable to be used. So it's very important to keep in mind when you're presenting cases in exam setting, that if you say traction bronchiectasis, it implies that you're not really up to date and you don't know that we're not supposed to use that term anymore, because bronchiectasis is a term we reserve only for primary airway abnormality. So airways, when they're dilated, they can be dilated because there's something wrong with them, or they can be dilated because there's something pulling them. If there is something wrong with the musculature or the wall of the bronchus itself, and over time it dilates, that's called primary bronchiectasis. If it dilates because there's something pulling it around it, either that's an acute abnormality or that's a permanent abnormality, that is no longer called as bronchiectasis. It used to be called traction bronchiectasis. If it was isolated to a certain part of the lung, it used to be called cicatricial bronchiectasis. Post-inflammatory bronchiectasis is still acceptable, but saying traction bronchiectasis is discouraged. So this first slice on the top is primary bronchiectasis, because you can see that the bronchi are dilated, but there is nothing around them to cause that. So is there anything to explain in the lung that the bronchi are dilated? No. So you have to, as an exclusion say that this has to be primary bronchiectasis. Whereas in this bottom one, you can see that the lung around it is grossly abnormal. There's volume loss, there's architectural distortion, and the bronchi within it are being pulled. So as they're being pulled, they're getting dilated. And this is where you would use the word traction bronchial dilatation. This one, again, you can very clearly see that the lung around it is very abnormal. So it was so grossly abnormal that this patient actually has signs of end-stage fibrotic lung disease. So one way of trying to figure out whether that's primary bronchiectasis or traction bronchiectasis, bronchial dilatation, is to look at the vessel wall, bronchus wall. Sometimes the bronchus wall can be very squiggly or irregular. That's usually a very specific sign of traction bronchial dilatation. So because a patient can have ILD and primary bronchiectasis, so if somebody has a mild ILD or mild reticulation, that is very clearly more than would be expected for dependent change. And the question is, well, does the patient have underlying bronchiectasis as well? So that is when you look at the morphology or the appearance of that specific bronchus. This one at the top, have a look at this and put some comments in the chat of what you think this is. Do you think this is primary bronchiectasis? Do you think this is ILD? Okay, take a minute and put something in the chat and we'll come back and discuss it. Okay, a bit of divided response there. So my question was, is this bronchiectasis? Is this traction bronchial dilatation? As in, is this ILD or is this nothing? Some of you have said bronchiectasis. Some of you had said, I'm assuming you mean primary bronchiectasis. Neda has said air bronchogram in concept of consolidation, and that's absolutely right. This is consolidation. So this is the point I was trying to make. There is sometimes you can see dilated bronchi in consolidation as well, and that presence of air bronchogram can immediately make you think, is this bronchus dilated or is this ILD? This appearance is a bit more prominent that you would see in normal consolidation. So when consolidation heals, or when depending on which stage you're imaging the patient at, the air bronchograms within a consolidation can also look irregular. So if you had that scan and you saw those bronchi, you can't diagnose that as permanent. You can't diagnose that patient with ILD, even if you were uncomfortable with the degree of or the diameter of the airways. You have to recommend follow-up, because in most cases that will resolve when that patient improves and that consolidation resolves. You would see that the bronchi will go back to its normal. So within active infection, within active inflammation, you can see dilated bronchi. And you can't label that as a permanent change. You can't label that as ILD or primary bronchiectasis within active consolidation, was the point I was trying to make. Other abnormalities quite commonly seen in ILD are cystic changes. And this can be very hard to differentiate even for the most experienced radiologists. So don't be alarmed when you find yourself staring at a cyst and not trying to figure out whether this is a cyst or whether this is emphysema. It can be hard. And it can be even harder because of the fact that the patients that have cystic lung disease also happen to be the same patients that can have emphysema as well. So a patient can have both of them at the same time, and that makes it harder to diagnose. When it's a cyst that is thick walled, like number 2, it's much easier to diagnose that. It's much easier to call that. But obviously, when you have thin wall cyst and thin to the point that you can't even see the wall or barely perceive the wall, then it gets slightly more tricky. If you look at number 4, you can see that this is a cyst because there's nothing else around it, immediately around it, that looks like that. You can see the wall. You can see it's a thin wall, but you can see the wall. When you look at number 1, and if the question is, does the patient have cystic lung disease? You have to look a bit more closely, and you have to look for the signs that can help you differentiate between emphysema and cystic lung disease. So in cystic lung disease, you are saying that the cysts are within the lung parenchyma. In emphysema, what you are saying that the cyst, what looks like a cyst or a space, is actually destruction of the airspace. So emphysematous spaces do not have walls. What they do have is remnants of structures that used to be normal lung stranding through them. So when you look, it's called a central dot sign. So the vessel that once upon a time used to supply that part of lung is still alive. You can still see a strand of it in the middle, and the surrounding airspace has since been completely destroyed. So in emphysema, if you look for the central dot sign, it will help you differentiate. So presence of a central strand, a central dot in a cystic space implies that this is actually what used to be normal lung once. So this is not actually a cyst, it's just end stage disease or end stage appearance of something. And in most cases, that will be emphysema. And in the context of ILD, that will be honeycombing, but we'll come to that in a bit. So moving on to more specific disorders, the first one we'll look at is sarcoidosis. Sarcoidosis is a very interesting disorder in the sense that not only is it multi-system, multi-organ, it has a very, very wide range of presentation in terms of what it can look like on imaging and also what the patient can look like. So sometimes it's an incidental finding. Sometimes the patients can be really, really unwell. And the age doesn't really help as well. They can be early 30s to late 70s. So it's a very difficult but interesting disorder to look at. And it also happens to be a very big exam favorite for a lot of examiners. So it's really important to be clear on sarcoidosis because sometimes it can also mimic or raise the suspicion of underlying malignancy. So it becomes really important to be very clear on not only the stages, but also what imaging can look like and what you need to do. In terms of the stage of diseases, I'm sure most of you know these stages already, but just to put that into context, is the probability of complete resolution reduces a lot depending on which stage of sarcoidosis you are in. When you are in the 4th stage or in the stage of complete fibrosis or early established fibrosis in sarcoidosis, there will never be a point that your lung will return to normal. If your fibrosis is stable, you can live a normal life. If your fibrosis goes on to be progressive, you can end up with right heart failure or pulmonary hypertension, and in the end, the only resort you will have is to be put on a transplant list. Stage 1, stage 2, stage 3, still potentially reversible, completely reversible, but the chances of completely resolving reduce as you go up in stage. It is a multi-system disorder. I'm not going to claim to be a neuroradiologist and tell you all about neurosarcoidosis, but sometimes the patients can present with symptoms very far away from the chest or have nothing to do with the chest. And if the differential happens to mention sarcoidosis, they can end up having HRCTs to exclude sarcoidosis. The patients can be completely asymptomatic from the lung point of view, even if there is very clear abnormality on the CT. So sometimes the CTs are to look for sarcoidosis in an asymptomatic patient, or it can be an incidental diagnosis you make for non-specific symptoms. In terms of musculoskeletal changes, they can be appendicular silicon, they can be in the skull, they can be in the hands, the feet. Like I said, I'm not going to go into detail, but this is just to put into perspective that the the patients can end up with an HRCT from a multitude referral sources. They can be orthopedic referral, or neurosurgeon referral, or a respiratory physician referral. If you had that skull X-ray in front of you, I don't think any of us would go with sarcoidosis being our first diagnosis. Most of us, and rightfully so, would think of diffuse or lytic metastases of the skull. So it can present in very alarming ways, in very progressive, destructive skeletal changes, but it can be multi-organ. And if the skeletal changes are very advanced, if the neuro changes are very advanced, it makes no impact, or it doesn't tell you in any way whether the lung is involved or not. So the severity of extrapulmonary sarcoidosis doesn't correlate necessarily with your thoracic implications or thoracic changes. And this is a gallium scan. I will open up the chat again and ask if anybody knows what this appearance in sarcoidosis is called. Okay, 30 seconds starting now. Yeah, most of you are absolutely right. This is the panda sign that is seen on the gallium scan. How many of us actually do gallium scan in our everyday to day practice in sarcoidosis? I don't think many of us do it. Again, this is a historical piece of information that is not really practiced very widely, at least in the UK anymore. We largely look at PET and MR and CT as the main imaging modalities we use for sarcoidosis. But panda sign is bilateral involvement of the parotid and the lacrimal glands in sarcoidosis. When it's superimposed on the normal uptake in the nasopharyngeal muscles, it can look like a panda's face. So that was what was described as the panda sign in sarcoidosis. This is called the 1, 2, 3 sign, or the typical chest X-ray that you will see. This will typically be in a young patient, early 30s, fit young man presenting with non-specific symptoms of lethargy, malaise, maybe low-grade fever. A very smart respiratory physician has done a serum ACE level, and that is increased, and that is what a chest X-ray looks like. So this shows you bilateral hilar enlargement, lobulated looking, and you can very clearly see that there's something in the right paratracheal space. So that's called 1, 2, 3. 1 being the paratracheal, and 2, 3 being the 2 hilar. Garland is a wreath or a string that is described to used to describe that appearance. This appearance is also called pawnbroker symbol or pawnbroker sign. These two signs are just used to describe the very typical appearance of bilateral hilar and right paratracheal lymphadenopathy. In a very not so long ago, the same appearance you could see in TB as well. But this appearance of these signs are reserved more for sarcoidosis. The pawnbroker sign is just, it's an interesting sign. It's just, the pawnbroker symbol is actually the symbol of the Medici family. So I don't know if many of you are very interested in history or not, but Medici family is the family of bankers that are famous for the art collections in Florence, Italy. But the Medici family symbol is actually 3 balls. That the legend was that there was a very famous giant that was slayed by a Medici man using 3 rocks that he threw at him. So that 3 gold balls hanging on a lamp are actually symbols of the Medici family. So pawnbroker sign is a type of banking that the Medici family came up with in Florence. So that's why it's called that sign. So the pawnbroker is actually the Medici family, and the symbol is the 3 gold rounded opacities. Again, reiterating the stages of sarcoidosis, hilar and mediastinal lymph node enlargement is easier to diagnose, is usually the initial presentation in younger people. And the question, and rightfully so, the differential that needs excluding is lymphoma. Lymphoma is seen in the same age group. The lymph nodes, if uncalcified, can be more confusing with lymphoma. If you see specks of calcification, it becomes more easy. You don't really see calcification in the acute presentation. It takes time to develop. The enlargement comes first, and the healing stage and the chronic stage sees that lymph node calcification. If you have calcified lymph nodes and they're slightly enlarged, you're more reassured that it's a benign pathology. But when you have non-calcified lymph nodes that are large and rounded with the loss of the fatty hilum, you really have to sample them. Even if you're radiologically very sure that this is sarcoidosis, the procedure or the norm is that the respiratory physician will still sample these nodes endobronchially and will have tissue diagnosis of sarcoidosis. Sometimes we see parenchymal disease with the nodal disease, and that's obviously stage 2. Stage 3 is when you see parenchymal disease only. And like I said before, the chances of spontaneous resolution decrease as you go up in stage. And the fourth stage of when they present with pulmonary fibrosis is obviously completely, there will never be a point that they will resolve completely or go back to how the lung was before sarcoidosis. It's not uncommon to see people with stage 4 sarcoidosis having no memory or no history of ever having stage 1, 2, or 3 sarcoidosis. So they could have had sarcoidosis 10 years ago, 20 years ago, a year ago, and not have realized it symptomatically. And like I said, the degree of acute change or the changes in the stages 1, 2, and 3 do determine the chances of you getting fibrosis, but it's not a linear correlation. So it's not like if somebody presented with very severe disease, very large lymph nodes in stage 1, we can predict that they will end up with stage 4. It doesn't work that way. The parenchymal extent of disease is slightly more correlatable, but some people respond very beautifully, some resolve completely, and some just go on to have this smoldering disease that in a few years can become very aggressive suddenly. So there's no way of actually predicting the prognosis of it based on a scan. So these patients don't go under routine surveillance of scans. The scans or the follow-up scans are more dictated by the clinical scenario. So the respiratory physician will see the patient. If they look asymptomatic, if they're doing well, they're not going to be getting scanned again and again. If they do deteriorate, if the lung function deteriorates, they get repeat imaging. And whenever they get repeat imaging, the question to you or the chest radiologist will always be, is there active disease? And what they mean by active disease is there nodularity? You can have calcified lymph nodes or you can have fibrosis and not have active disease. Fibrosis will always be fibrosis, even if it's stable and will stay exactly the same severity for the next 20 years. It's not classified as active disease. If you have lymph node enlargement that is calcified and is stable, it's not called as active disease. It's the parenchymal disease, the changes in the lung parenchyma that determine whether that is active disease or not. And the abnormality you're looking for is nodularity. Nodularity of the fissures, nodularity of the bronchovascular bundles. And when the nodularity is so advanced that there are a lot of small nodules sitting next to each other, they can also coalesce together. And what is traditionally called the galaxy sign. So it can look like there's a collection of nodules there, and it can also look like one large nodule. If somebody asks you, are you absolutely sure this is not an incidental cancer in the middle of all that sarcoid change? The answer is no, there's no way of knowing. Are you going to biopsy that? No, you're not. You're just going to go on and follow up the patient. These nodules, these coalesced nodules can sometimes be very prominent. They can be bilateral and they can be quite worrying looking. So then the differential for bilateral metastatic disease comes into play. And sometimes then when you don't see the micronodularity around it, and when you see these bilateral nodules, sizable nodules, it is sometimes worth getting a diagnosis just for reassurance purposes. This is just a magnified view of the nodularity. So nodularity of the bronchovascular bundles, perilymphatic, peribronchovascular, and the fissural nodularity. Whenever you have a scan that you are thinking down the lines of sarcoidosis, your eye should immediately be drawn to the fissures. If you scroll up and down and the fissures are nodular, you're pretty sure by that point that you are going down the right route and you are going to call that patient as parenchymal sarcoidosis. When it's stage 4, then the diagnosis isn't that easy to make. because you have a lot of other diseases that can give you upper to mid zone fibrosis, and sarcoidosis happens to be one of them. On a chest x-ray especially, the appearances are very non-specific. So they can be asymmetrical, they can be symmetrical more common. Upper to mid zone fibrotic changes, and then the differential has sarcoidosis in it. I will open up the chat and I will ask you guys to tell me what else that can be. So differential diagnosis for upper to mid zone fibrosis. 30 seconds. Okay, perfect. Thank you. And it's great to see all of you engaging with the chat, and all of you are giving very good differentials. Somebody has said advanced hypersensitivity pneumonitis, and I would really encourage you guys not to use terms like advanced. It's either acute or chronic or subacute. We'll come to HP in a bit, and hopefully by the end of today's session, you will know what to call acute and chronic in terms of HP at least. Yes, the difference is absolutely right. Upper to mid zone fibrosis, particularly apical fibrosis, you can have TB, radiation, unclosing spondylitis, silicosis, pneumoconiosis. And the thing that makes it slightly more confusing, especially with chest x-rays, is that not only TB, but RA, silicosis, pneumoconiosis, all of these can have calcification. So they can have lymph node enlargement of the same distribution, they can have lymph node calcification, they can have a bit of parenchymal calcification, and the differential doesn't really change. So if I now asked you what is the differential of calcified lymph nodes with calcified lung nodules and upper to mid zone fibrosis, your differential would almost be the same. So it doesn't really help. Once you have upper to mid zone fibrosis, you can't really narrow it down any further than the differential you already have, especially based on X-ray. There is an appearance on CT that is quite specific to sarcoidosis. It's unfortunately not that commonly seen, but when it is seen, it becomes very easy. And those of you who have seen it once will always remember what it looks like. And the way to remember it is when you have a CT chest and it's a supine scan, what you want to look at is when it's sarcoidosis, it's upper to mid zones, and it looks like somebody has taken the bronchi and they have pulled them back. So like if somebody was standing in front of you and facing the other way and you took their arms and you pulled them back, that's how it looks like when you look at the lung. It looks like there's somebody pulling it back laterally. So the bronchi are going to curve back and curve laterally. And all the architectural distortion, all the volume loss happens in that direction. And it's a very specific appearance. And once you see it, almost nothing else causes it. Especially if it's symmetrical. So if it's TB, it's going to be more irregular. When it's sarcoidosis, it's going to be more specific or more uniform. So that's what you can look for in terms of CT. So it becomes slightly more helpful. Can it be PMF? Yes. Sarcoidosis does not cause PMF. No. So PMF is progressive massive fibrosis. For those of you who don't know, this is commonly seen in occupational lung disease. So the posterior pulling is not specific to PMF. PMF can happen anywhere. So wherever that massive fibrosis or mass-like fibrosis is, it's going to pull towards it. So that PMF can also be in the lower lobe. It can be all over. It's predominantly upper to mid zone, but it's not specific to posterior architectural distortion. Again, CT upper to mid zone fibrosis. This is what end stage or fourth stage of sarcoidosis looks like. What happens in fibrosis is with the part of the lung that loses volume or collapses or becomes fibrosed, the lung around it is inevitably pulled to expand. So you have compensatory hyperinflation of the lung around it. For example, here you can see this part of the lung almost looks like it's turning into a bulla because the fibrosed part of the lung is pulling it. What happens in that scenario is that um, that will ultimately turn into a cavity. You can have a cavity inside a dead part of the lung or a fibrosed part of the lung, and that cavity is essentially a breeding ground for opportunistic infection. So that's what happened in this CT, and that space has actually grown in aspergilloma. So it's a very common complication in end-stage lung disease or fibrosis is when you have cavities, they do fill up with aspergilloma. This is a more typical appearance of the calcified lymph nodes and the volume loss. Again, a more advanced, more typical appearance, but if you can appreciate, it has gone down into the lower lobes as well. So the more severe the disease gets, the more it comes out of its comfort zone and starts going to the lower and mid zones as well. It is a multi-system disease, so at some point or the other, they may present with symptoms from another body organ, or abdominal pain, or cardiac arrhythmias, or general ill health. And if somebody does progress a lot, or they're quite symptomatic, they can have PET scans to look for uptake and extent of disease. In terms of cardiac abnormality, what was previously done with nuclear imaging is now done with cardiac MR. So I don't expect you to be experts in cardiac MR, but in terms of exam purposes, just something to remember by when you have infiltrative cardiomyopathy, or you have an abnormality in the heart muscle that has infiltrated the muscle with abnormal cells rather than ischemia, you have mid-wall or epicardial inflammation. So that part of the lung shows as late gadolinium enhancement on late GAD images and cardiac MR. So mid-wall enhancement is very typical for infiltrative cardiomyopathies, and sarcoidosis is one of them. We're going to come on to hypersensitivity pneumonitis. So let me see if we are coming up to, yeah, we're coming up to 7 o'clock. Let's take a 5-minute break, and when we come back, we'll start with hypersensitivity pneumonitis. See you guys in 5 minutes.